Alrighty, here we go. Hello everyone, and thank you for watching this program on diagnosis pointing and the 1500 form. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information in this presentation is for educational purposes. We're going to be going through some clinical examples. Please understand that this is not a substitute for your thorough clinical decision making. The information is not intended to be legal advice. We don't provide legal services. CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Just a little bit about myself before we get going. My name is Dr. Marty Kotler. I am a chiropractor. I practiced for 16 years. And about 12 years ago, I started a company called Target Coding. Many of you may have heard of my company. We've been around quite a while. I'm certified in CPT coding. I'm a certified professional compliance officer. We've trained over 3,500 chiropractors and staff members over the last 12 years through our personalized one-on-one consulting and at seminars throughout the country. Our areas of expertise include compliance as it relates to HIPAA, Medicare, record keeping, billing, coding, treatment plans. I've written 10 training manuals on chiropractic billing, coding, and documentation. I write articles for many magazines and journals throughout the country like Chiropractic Economics, Dynamic Chiropractic, The American Chiropractor. I also write articles for many state association newsletters, and I'm a guest speaker at many state association conventions throughout the country. All right, so let's begin now. Let's talk about the 1500 form. This form is developed and maintained by an organization called National Uniform Claim Committee, NUCC. The website is nucc.org. So this is an organization, not the federal government. A lot of people think the 1500 form is governed by Medicare and federal government. No, it's governed by NUCC, National Uniform Claim Committee. Now, they get input from insurance companies and Medicare and many organizations, but they're in charge of it. So there's a form right now. It's the 0805 form that became effective on April 1st of 2014. And this is a full view of the form. There are 33 boxes, we'll call them, or fields. I'll probably call them boxes throughout today's presentation, 33 boxes. And I like to cut the form in half. The top portion of the form, the first 13 boxes, it's pretty straightforward. Box 1, you're going to click, or in your software, you're going to X out one of the boxes if it's a group health plan or Medicare or other insured's ID, patient's name, birth date, the insured's name, address, relationship to insured's address. A lot of basic information. Box 8 is left blank. That's reserved for NUCC use. Box 9 is the other insured's name. Box 10 is important. Box 10 is where you will complete, is the patient's condition related to employment, auto accident, or other accident? Very important. Box 10. For those of you that see PI patients, you see PI patients, and let's say the patient's auto insurance benefits runs out, and now you want to bill the patient's regular health insurance. Happens all the time, right? Make sure you check yes to 10B. See, if you check no to employment, auto accident, and other accident, and yet this condition is related to the accident, and now you're getting reimbursed by the patient's regular health insurance, they may come back and ask for the money back because they might not pay for injuries relating to an auto accident. You have to be transparent. You have to fill out these forms totally honestly and completely. Few things on the back of the form that I'm going to go over in a few minutes that most people aren't aware of, but you're attesting to the fact that everything on this form is true. If you are treating a patient for an auto accident and you're billing their regular health insurance, you must check yes to 10B. Some doctors, after the patient's auto accident runs out, the attorney might say, well, the patient has Medicare. Why don't you bill Medicare? Okay, if you want to bill, they're probably not going to pay. But if you're going to bill Medicare, you must check yes to 10B. Now, box 11, just zoom in on box 11 here. So box 11 says, is there another health plan? Medicare makes a big deal about this box. They want to know if there's some other health plan that's responsible for the care of this patient. They don't want to pay, so they want to know who that is. So, is there another health plan? Yes. If you check yes, then you have to go back and complete boxes 9, 9A, and 9D. So make sure you check yes or no to box 11D. Box 12, let's zoom in on that. That's the patient's or authorized person's signature authorizing release of medical information. Many doctors will just automatically put signature on file for box 12. Well, do you really have a signature? If you do, that's fine. When I audit doctors and I review their patient charts, I'd say 25% of the time, the doctor's staff and the computer-generated forms automatically print out signature on file, signature on file. Same thing for box 13, signature on file. Just make sure you have a signature on file. If you don't have one for boxes 12 and 13, then have the patient sign these as the original, or you can create a form. Some of my clients, they don't have fancy software, so I've created a separate standalone form to satisfy boxes 12 and 13, so then you can go ahead and put yes to signature on file. Now we'll start working on the bottom half. These are boxes 14 through 33. 14 is an important one. This is the date of the current illness. So most of the time you're putting the initial date that the patient came in. If it's an auto accident or workers' comp, you're going to put the date of the accident, and that never changes. But for regular insurance and Medicare, that box is dynamic. If the patient comes in today, you'll put today's date, and then you see the patient for a couple of weeks or a couple of months, and they stop coming in. When that patient comes back for an exacerbation, a change in condition, update box 14. So make sure you keep box 14 fresh and as new as possible, as close to the dates of service as possible. Otherwise, it could be a problem. What do I mean by that? If you have the date, let's say you have July 14th of 2012 in box 14. This is 2017. The insurance company will say, wait a second, this patient is being treated for over 5 years? Oh, we're not going to pay. We're going to consider the care not medically necessary or maintenance. Box 15 is not that much of a big deal, but some insurance companies do make a big deal about it. This is where you need a identifier or qualifier. A qualifier. It's going to be 454 most of the time for initial treatment. Next, let's take a look at boxes 17. It says name of referring provider, and 17B. Some health plans require that you put the name. If you get a referral from another doctor, that you're required to put the name of that doctor in 17. So let's say you work with Dr. Smith, orthopedic surgeon, and you have a relationship with him. You refer to him, he refers to you, and he refers you a patient. And you're going to bill maybe a consultation code. Then you would definitely need to put Dr. Smith's name in 17. You're going to use DN as the qualifier. And then in 17B, you're going to put Dr. Smith's NPI number. If you ever get denied from an insurance company that says, we need a referring provider, and you or your staff member goes, wait a second, this patient was a walk-in or referred from another patient. This patient wasn't referred by a doctor. This is an insurance company that needs a name of a doctor in 17, or else they're not going to process your claim properly. It's not that often and not that common, but I have seen this. So the doctor and the staff are perplexed. They don't know what to do. This patient was a walk-in or referred from another patient. But we have to put the name of a doctor in 17. What you should do is put your own name in, doctor. Yes, put your own name in 17. And your NPI number in 17B. That'll probably fix that issue. And let's take a look at box 19, add additional claim information. Some of you may need to put, for Medicare purposes, the date of the x-rays or when the part exam was taken. Let's take a look at box 21. Oh boy, 21. That's the main box here on this form as far as I'm concerned. Box 21. That's where you put your diagnosis codes. There's room for up to 12 diagnosis codes. So you're going to enter the diagnosis codes. Don't list more than 12. 12 should be enough. Typically 4 is enough. But if you want to put up to 12, you can. You want to report ICD-10 codes to the highest degree of specificity. You don't have to type out the words, just the letters and the numbers. We're going to come back to box 21 in a few minutes when we talk about diagnosis pointing as it relates to 21 and 24E. Let's keep going. Let's take a look at box 24. 24B. 24B, that's the place of service. So if you treat a patient in your office, you're putting the number 11. Some of you may make house calls. That's great. When you fill out the claim in box 24B, you should put the number 12. That's the patient's home. If you go to the patient's place of employment to treat patients, which quite a few of my clients do, you would use the number 18. Some of my clients treat patients in nursing facilities. That's number 32. So make sure you're using the right number. There's probably about 75 different places of service. I'm just giving you some of the more common ones here. Make sure you're using the correct place of service code number. Everything else on the form stays the same. And let's take a look at 24E. This is the pointer box where you're going to use a letter based on the letters that were completed in box 21. Let's take a look at box 33A. Get quite a few questions on, okay, do I put my NPI number in 33A, the individual, the group? Typically, this is how it goes. If you're an individual practice, solo practitioner, you're going to use your individual NPI number in 33A. If you've created a group practice, which could be a lot of different things depending upon your insurance company. We also do credentialing here at Target Coding. So this comes up where we're helping the doctor get credentialed with certain insurance companies, and a group needs to be formed. And well, the insurance carrier says, we need your group NPI number. And the provider says, I don't have a group. I'm a solo practitioner. I'm just starting a practice, or I'm just in practice by myself. I don't have any doctors. Well, you have a tax ID number, right, doctor? Yes. Well, if you have a tax ID number, you have to form a group NPI. We hear that sometimes when we're going through credentialing with our providers. Natasha is an expert on credentialing. Those of you that need assistance with credentialing, need an NPI number, need a Medicare enrollment number, that's called a PTAN number, you need assistance with CAQH, let us know. We could help you with that. Now, I mentioned the back of the form. Some of you, I think I was in practice 5 years before I ever turned over the form to look at the back. I didn't even know there was anything on the back. Take a look at the back. Well, sure, you could take a look at it, but let me just summarize it. The back of the form has a lot of important information. The back of the form says that you are attesting to the fact that the services that are being rendered are medically necessary. And if you file a claim that has false information, you could be accused of a False Claims Act. Even if you do, for example, you bill an insurance company and you don't collect the copays or deductibles, that claim that you sent could be considered a false claim. If you're billing for active treatment getting paid from an insurance company, but your notes look like it's wellness care, that could be considered a false claim. It also says, for this claim, whether submitted by me or on my behalf by my billing company, it complies with all the laws, rules, regulations. It's not limited to just anti-kickback and Stark law. The services were medically necessary and personally furnished by me. If you have any comments, suggestions, send them to CMS in Baltimore, Maryland. There's the address. I have sent information in. I thought the old form that had only 4 boxes for diagnosis codes, 4 positions in box 21, wasn't enough. So I voiced concerns. There are other things about the form that I think should be improved because the form is not built for chiropractic care, in my opinion. So if you have any suggestions or comments about the form, you can. They do listen to outside comments, so you could send it in. Don't send your bills to that address. Just some comments you can send there. Let me give you some clinical examples. Mrs. Miller comes into the office. She's got lower back pain and pain radiating down the posterolateral aspect of her right leg and foot. She has some tingling in her calf and stiffness in her hip. She has a history of fibromyalgia. Okay, now we do an exam. We do straight leg raise. Now, let me back up here. As far as choosing a diagnosis, you need to justify it nowadays more than ever before, especially with ICD-10 and the scrutiny on diagnosis coding. Years ago when patients would come in, they'd say, Dr. Kotler, I have lower back pain and I have pain radiating down my leg. I just diagnosed sciatica. I didn't do any orthopedic tests. I didn't do any neurological tests. Sciatica. And I just sent it in. It's kind of, in a lazy fashion. I really didn't, put too much thought in it. And, everything seemed to be fine. The patient was getting better. My claims were getting paid. So everything was fine. Well, those days are over. If you're going to diagnose a patient with sciatica, you must do straight leg raise. You must do a few ortho-neuro-chiro tests to support that diagnosis. There are many managed care plans, third-party administrators that will not pay unless you do certain tests. So in this case, Mrs. Miller, we did straight leg raise, we checked reflexes. She has spasm and subluxation, so we started off with a combo code, which is low back pain with sciatica. On the right side, that's your M54.41, spasms, subluxations. We also listed the tingling, that's R20.2, and the complicating factor of fibromyalgia, M79.7. Now let me show you a simple Medicare example for 98940. Very simple here. Mrs. Smith comes in. She has neck pain and neck stiffness. I do an exam. We're going to do the PART method. Palpatory tenderness, there's your P. Subluxations, there's your A. She has subluxations at C5, C6. She has restricted motion, painful and restricted motion in the cervical spine. There's your R. And then she has hypertonic muscles in the cervical region. There's your T. We also took x-rays. We found disc degeneration at C6, C7. Okay, we're going to bill 98940, and we're going to link or combine, I call this combine code pairing, like you pair wine and food, you should be pairing your procedure codes and diagnosis codes. You wouldn't pair neck pain with an extremity adjustment, right? That wouldn't make sense. You wouldn't pair, a knee problem with a cervical adjustment. So in this case, we have the M9901, that's the cervical subluxation, and there's the disc degeneration, M50323, neck pain and spasm. Give you another example here for 98941. When I see 98941, I expect 3 areas of complaint. So Mr. Williams comes in, he's complaining of low back pain, mid back pain, and neck pain. Great, that shows compliance. Exam, tenderness in the cervical, thoracic, lumbar area, subluxations in all 3 regions, hypertonicity in the thoracic region, and restricted and painful cervical range of motion. We have x-rays, which show degeneration in the neck and lumbar region. So now, because we're billing 98941, I'd like to submit at least 3 of the subluxations as primary diagnosis codes and 3 associated diagnosis codes. So here we have lumbar subluxation, with lumbar radiculopathy, and cervical subluxation with neck pain, and thoracic subluxation with spasm. Let's take a look at some diagnosis pointing examples. This is where you want to link your procedure codes and your diagnosis codes. So here's one example. We have tons of different examples. This is a group health plan. This is a sample for a chiropractic manipulation adjustment 98940. We're doing manual therapy. We're also doing unattended electrical stim, and we're going to do therapeutic exercises. So take a look at box 24D. It says 98940. Now take a look at box 24E, letters A and B. So I'm pointing my chiropractic adjustment to A, which is M5116, which is lumbar issue, and B is low back spasms. So there's the two lumbar diagnosis codes. All right, let's take a look at the next line item, 97140. That's manual therapy. Where am I doing that? I'm doing that on C and D. That's cervical and cervical radiculopathy and myofascial pain syndrome. Yeah, that makes sense. I'm doing manual therapy, specifically myofascial release. Why? Because the patient has myofascial pain. Okay, that pairs beautifully. So I'm just doing that on the neck. That's why I'm using the 59 modifier. Then let's take a look at the third service that I'm providing. 97014 is unattended electrical stim. It could also be billed as G0283. That's a HIPAA code. Where am I doing that? I'm doing that on M5134. That's a thoracic issue. And M54.6, that's thoracic pain. So I'm doing the electrical stim only on the thoracic region. See, I'm trying to tell as much of a story as possible on this claim form, so I'm not asked for my notes, so there's no delay in the claims. Then the fourth service provided on this patient is 97110, therapeutic exercises. Where am I doing that? Only on the lower back. I'm pointing that to positions A and B in box 21. So that's called diagnosis pointing and pairing your procedure codes with your diagnosis codes. Here's another example. Medicare patient. 98941 is the line item with the AT modifier, which means active treatment. AT to Medicare, those two little letters, A and T, tells Medicare a lot of information. It tells them that you are treating this patient for active treatment, which means this patient has a painful neuromusculoskeletal system caused by a subluxation, and you've diagnosed that subluxation through either the part exam or x-rays. And your treatment of the patient's subluxation is going to help them do their normal daily activities. AT also means that you've read the Medicare guidelines and you understand them. And anybody in your office that has anything to do with billing and coding for this Medicare patient, not only the doctor but the staff, understand the Medicare guidelines, have read the guidelines and implement them and have regular trainings on it. Wow! All of that just for the AT modifier? Yes. And then we also did traction on this Medicare patient, 97012, with the GY modifier. GY, do we need to use that? Well, if the patient has a secondary insurance, do that. So it passes through the Medicare payment system and gets over to the secondary. Next. Oh, here we go. Here we have a PI example here. So this patient comes in, a 3-region chiropractic adjustment, therapeutic activities, which is much different than therapeutic exercises. Hopefully you know the difference between the two. And 97124, that's massage. So 98941, where are we doing that? We're doing that to A, B, C, and D. So we're doing that to the cervical, thoracic, and lumbar. We're doing the therapeutic activities only to the cervical and thoracic. And then we're doing the massage only on the extremity. This patient has a knee problem. So that's why we're using the 59 modifier. Now back to making sure you can justify your diagnosis codes. Sacroiliac sprain, or any type of sacroiliac joint problem like sacroiliac joint subluxation or sacroiliitis, requires you to do a few things to justify it. So, for example, let's stick with sacroiliac sprain. You see it on your screen, S33.6. You submit that to an insurance company, and then you get a call, or you're contacted by the case manager or somebody over at the insurance company, or if it's a malpractice case or there's a state board issue, you're now being questioned. So, Dr. Kotler, explain, how did you come up with sacroiliac sprain as a diagnosis? If you're ever asked a question like that, you want to feel comfortable. You want to be able to answer it confidently. Otherwise, you could be made to look silly if you don't know how to answer it. So if you're questioned, hey, Dr. Kotler, can you explain, how did you come up with sacroiliac sprain as a diagnosis? Hopefully you'll say something like this. Take a look at the screen. Well, the patient had pain in one or both SI joints. I did Yeoman's orthopedic test and Ganslin's. Those are the two gold standard tests for SI joint involvement. I would recommend you do them. I speak to some chiropractors, they go, Marty, I don't do any ortho neuro testing. I don't own a reflex hammer. I don't have, I don't check blood pressure. As I mentioned earlier, when I first started practicing, patients would come in with back pain and leg pain. I just diagnosed sciatica. I didn't do anything. So I don't recommend it. Even if you're a subluxation-based chiropractor, I still recommend you do a couple of ortho and neuro tests to help protect you and your practice. If you're ever put on the witness stand and you're asked, how did you come up with the sacroiliac joint issue? It would be a good idea to say, yeah, we did Faber-Patrick, Eli's, there was palpatory tenderness and edema, there was hypotonicity around the area, there were subluxations. Yeah, and you may diagnose a patient with cervical radiculopathy, and you may get questioned, hey, Dr. Kotler, how did you come up with that? Well, I did Jackson compression, Valsalva, I checked reflexes, looked for myotomal weakness. And here's a page out of a book. There's a book that I highly recommend that every chiropractic practice in the country should have. And there's a section in this book that has about 25 of the most common diagnosis codes that chiropractor sees, and then the subjective and ortho and neuro and chiro and imaging and the diagnosis code to support it. So, for example, at the bottom of the page here, you may diagnose a patient with cervical brachial syndrome. Great. How did you justify it? Well, I did Wright's, I did Aston's, I checked for myotomal weakness, there was some scapular winging, there was a subluxation, took x-rays. Yeah, I mentioned this earlier. Very important to pair your codes, just like wine and food. Patient comes in, you diagnose them with shoulder stiffness or strained quadriceps muscles. Therapeutic exercises pairs beautifully with those diagnosis codes. So pairing is important. Oh, yeah, I was mentioning a book that has a whole bunch of really good stuff on coding and billing and diagnosis coding. And this is a page out of the book that shows you how to pair your therapeutic procedures. If you do therapeutic procedures like therapeutic exercises, 97110, there's a section in the book that gives you the diagnosis codes that would be the most appropriate in the cervical, thoracic, lumbar region, and the extremities. Okay, so just a few closing comments. Please check with all the carriers you bill prior to submitting claims to ensure that it is compliant. We can't guarantee that this information will guarantee in payment from any patient or insurance company, and we're not responsible for any insurance carrier laws, rules, guidelines that change, and they change all the time. So it's important to do your best to stay on top of these changes, attend seminars, attend webinars, and join your national and state professional associations. Here's our contact information. Email info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. Our HIPAA secure fax number is 844-831-2333. 2347. Let's take a look and see if any questions have come in. Oh, before we get to questions, this is the book that I was referring to. It's the book on the best chiropractic ICD-10 and CPT codes to improve reimbursement. You can call that 800 number to order it, and or you can go online. And it also provides, this is a really good part of the book, it gives you the long-term treatment diagnosis codes for many areas of the body. For example, a herniated disc will get paid for more visits than simple muscle spasm. So this book provides you the long-term and short-term treatment diagnosis codes, and there's a whole bunch of what I call these cheat sheets or quick guides. And then there's an FAQ section, which is pretty good. I've been accumulating questions over the years, and so these are the answers to the questions. So what's the difference between cervical brachial and cervical radiculitis? What's the difference between disc disorders and disc displacements? What's the difference between myalgia, myositis, and myofasciitis? So it's a good section of the book. Even if you're in practice 25, 30 years, don't be embarrassed if you don't know the difference between radiculitis, radiculopathy, and myelopathy. It's okay. Oh, we also offer billing and coding policy manuals. It's very important to have a billing and coding manual that describes your billing and coding policies and procedures. So why should you have a billing and coding policy manual? Well, for 3 reasons. Number 1, your staff. Your staff want organization. They want leadership. I've been in over 300 chiropractic offices over the last 12 years doing on-site trainings. Staff want organization. They want to work in an ethical and trustworthy atmosphere. Well, guess what? A billing and coding policy manual creates that culture of compliance. It's an extension of your mission and values. And if you ever have a staff member that just quits, that's angry, and now the staff member wants to accuse the business owner of wrongdoing, a billing and coding policy manual can contain ammunition to help you defend against any alleged billing and coding misconduct. Number 2, you should have one for state board investigations, or a malpractice, or an insurance company comes knocking on your door. A billing and coding policy manual can prevent audits. And if you're ever audited, it could mitigate fines and penalties. I'm working with a couple of doctors right now where I've created billing and coding policy manuals. Even after the audit was initiated, it shows good faith that you're making attempts to do things right. You look really bad and unprofessional if you can't prove to an investigator, a state board, or even a patient, what are your billing and coding policies? They must be formal. That means in writing and kept track of in training logs. And finally, you should have one for yourself, for the doctor. A billing and coding policy manual is a custom-made document for your particular type of practice. A lot of the doctors I work with, they do full spine adjustments. Patient comes in, even if they have neck pain, the doctor's adjusting the thoracic, lumbar, checking the knees and ankles. So what's your policy on adjusting full spine? But you only bill 98940. So a billing and coding policy manual allows you to tell your story in a professional manner. It'll definitely help you SWAN, which is one of my favorite acronyms, sleep well at night. So we have ones specifically for Medicare and OIG compliance manual with policies and procedures. It includes comprehensive, customizable compliance manual, policies and procedures personalized for your practice, training logs and forums, chart audit tools, proper ABN use, the $75 rule, prompt pay discounts, opt-out rules. It's all part of the billing and coding manual. We also offer a very comprehensive HIPAA compliance program. I think it's the most comprehensive one on the market. I recommend you shop around if you're looking. Make sure you're comparing apples to apples. Ours is the Mercedes, the Rolls-Royce. There's nothing wrong with Hondas and Toyotas, but we sell Mercedes and Rolls-Royces. So just make sure you're comparing when you're shopping around. And we also help acupuncturists with billing and coding and documentation. If you do acupuncture in your practice, you should have an acupuncture billing and coding policy manual. And we also do seminars and webinars. Many of them are approved for CEUs. If you just want to chat with us, see, a lot of people think that, oh, target coding, they're the insurance guys. We're not the insurance coding people. We're the compliance people. Compliance relates to everything. Your cash patients. Can you do prepays, discounts? Do you have to put money in escrow accounts? So we're the compliance people. We don't just talk about insurance codes. So if you have any questions about compliance as it relates to your practice, set up a 15-minute call with us. There's no charge. Then here's our contact information: info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. I want to thank everybody for attending. I hope you learned a lot. Let's take a look at the questions that have come in.